Welcome to the Glucose Never Lies podcast, where science meets real-life experience to empower diabetes management. I'm John Pemberton. I've lived with type 1 diabetes since 2008 and have spent nearly 20 years mastering both the science and art of managing it. Through personal experimentation, published research, and my work as a diabetes specialist dietitian, I've gained deep insights into what truly makes a difference. When my son Jude tested positive for type 1 diabetes antibodies, I realised that all the knowledge in my head was wasted if I couldn't communicate it in a way that was clear, actionable, and easy to come back to. So I built the Glucose Never Lies education programme, a free online resource designed to teach people diabetes management exactly the way I'd want people to understand it if they were looking after my son. After battling a functional motor disorder for many years and recently experiencing a major depressive episode, I was eventually pulled out of that hole by my friends, family, and professionals who helped me get back to being me. That experience taught me the power of giving, and this podcast is my way of giving back. My co-host Louise is a highly experienced diabetes nurse with over 20 years in the field. She brings a wealth of knowledge, and her superpower is making complex diabetes science accessible and practical for everyday life. She is the best diabetes nurse I've ever worked with, and there have been some good ones. Most importantly, she keeps me in check and keeps the podcast on point. So, if you're living with diabetes or supporting someone who is, we want to make things easier, clearer, and importantly, more enjoyable. We hope you enjoy the content. If you do, please share it with those who may like it too. As a disclaimer, the information shared on the Glucose Never Lies podcast is for informational and educational purposes only. While we discuss strategies and insights for diabetes management, this podcast is not a substitute for professional medical advice. Always consult your healthcare team before making any changes to your diabetes plan. That done with, let's get into the content. 14, which is overcoming insulin resistance with type 1 diabetes. So this is probably going to be a really long podcast for the usual sort of 20 to 30 minutes because there's so much to cover. And there's actually 8 different ways that insulin resistance plays into people with type 1 diabetes. And there are several ways to tackle insulin resistance as well. And why might this be important to you? Well, people with type 1 diabetes, we know, end up with having higher insulin doses than a person without diabetes. And that particularly makes it very challenging because the research is pretty clear that the more insulin a person takes relative to their body weight with type 1 diabetes, the higher the risk of heart attacks and strokes, and actually all-cause mortality, because we know excess insulin is going to cause some issues, certainly with regards to cardiovascular issues and obviously all-cause death. So it's not that insulin is a bad thing. It certainly is not. It's life-saving. It's amazing. It's the reason why everyone who's listening to this is alive. So we should be totally grateful for that. And it's not a bad thing. But there's always sometimes too much of a good thing. And certainly with type 1 diabetes, there are specific challenges that we have that people without diabetes don't have when it comes to insulin resistance. But at the same time, there are several ways that we can combat this. And that's the plan within this episode, is to talk about these 8 different types of insulin resistance. And then most importantly for each of them, let's talk about how we can manage it. But before we get into that, what we need to do is sort of understand what is going on for people with diabetes in comparison to people without diabetes, and then start to think about what insulin resistance might look like in terms of units, and then go on to talk about the causes, and then most importantly, what can you do about it? So you don't necessarily have to capture everything. You get your full understanding of the mechanisms behind it. I am going to go through them, but if you're thinking at a certain point, wow, this is a bit heavy, feel free to skip towards the solutions if that's the type of person that you are. If you're just going to do something, then great, go for it. But I'm the type of person who wants to know why, and therefore why things are working, and that gives me the motivation to go and tackle them. So I'll leave that for you to think about as we walk along. So here is the cusp of the problem for people with type 1 diabetes compared to people without. Is people without type 1 diabetes, their insulin goes from the pancreas into what's called the portal vein. And that's the blood vessel that connects the intestine, where our food gets absorbed, to the liver. And it's just above the portal vein, the pancreas. And what it does is for people without diabetes, when they eat food and their glucose goes into their bloodstream, the pancreas senses that, increases a lot of insulin to the portal vein, and the majority of the insulin is captured in the liver, and also the majority of the insulin is deactivated once it's been used in the liver. So it doesn't really get out into high concentrations into the peripheral blood supply, which supplies your heart, your kidneys, your brain. So the levels are much lower, obviously enough to make sure that insulin gets into all those tissues, but the highest levels are in the portal vein and much lower levels are in the rest of the blood supply. You flip that for people with type 1 diabetes, they've got virtually no insulin production from the pancreas, therefore their circulating levels of insulin in the portal vein are very low, therefore the capture of glucose in the liver is very low, but also they give their insulin into the subcutaneous fat tissue. So therefore all the insulin absorbed into the peripheral blood supply, which means that the concentrations are much higher in the peripheral blood supply with a person with type 1 compared to a person without. And that is key as we go through, because it is that circulating peripheral level, high levels of circulating around the body of insulin, that leads to a higher level of insulin resistance and can increase the risk of certain problems, certainly cardiovascular health, with the thinking about the heart cells and thinking about the buildup of atherosclerotic plaques or fatty streaks in the cardiac tissue. So it's that real difference between someone with type 1 diabetes. They're going to have to give higher levels of insulin, full stop, and also their insulin levels in their peripheral supply is much, much higher, 4 to 8 times higher than a person without diabetes. So even with the same diet, the same everything, the person with type 1 diabetes is at a disadvantage from a metabolic standpoint because of obviously their circulating peripheral levels are high. So that is a key point to understand, and that is why knowing your units per kilo and having an understanding of that of insulin and thinking about ways to keep that under control is actually very important when it comes to your future health. So that's the key point of understanding as we kind of move through here. Now, what I'm going to talk about is the 8 different ways that insulin resistance manifests itself, and that's called the Ominous Octet. Now, I'm not going to take any credit for this whatsoever. The Dr. Ralph DeFonso is basically the person who has done all the work over a lifetime of research. And if you look on the blog, I'll put a link to a few amazing podcasts that have been done on the drive with Peter Attia that basically walk through this much better than I can, but it talks about insulin resistance in a general format. I'm going to link this directly to people with type 1 diabetes and what we know we can do. So I'm not going to pretend I've made up these 8 different routes, and I've certainly not researched any of them and been involved in any of the trials, but I've certainly spent a long time trying to understand this, because for me, knowing how insulin resistant you are and how ways to improve it is a key to good glucose control or in target glucose control, and certainly looking after your health in the future. So just a disclaimer there, I'm not claiming that this is certainly not all my work. So the Ominous Octet, what types of insulin resistance are there? Well, there's liver insulin resistance, muscle insulin resistance, beta cell dysfunction, hyperglucagonemia, brain insulin resistance, gut hormone dysfunction, fat cell dysfunction, and renal cell or kidney cell dysfunction. So we are going to spend a bit of time diving into those, hence it's going to be a longer episode. But if you understand how insulin resistance happens at those each of those 8 areas, you'll start to understand why certain things that you may do may actually prove a benefit. And what we will go through is what can be done. So importantly, we have 8 different types of insulin resistance, and we could stop there and go, wow, this is really crap for a person with type 1 diabetes having all these things to go against. What we really want to know is what can you do? And essentially it works on a pyramid. As the base level, what things that you can do, activity is one of the highest order things. Then obviously weight management, making sure your fat mass is not too high. Obviously, nutrition plays a big part in terms of making sure that the dietary composition doesn't make insulin resistance worse. And then there are a whole host of pharmacology options. You're probably well aware of GLP-1s like Mounjaro and semaglutide, and we'll discuss those. There are also SGLT2 inhibitors that help at the kidney level. And then we also have something that helps with fat insulin resistance called pioglitazone. So again, I'm going to talk through all of those once we've been through what actually causes the insulin resistance. So hopefully that'll keep you interested for what you can do. But like I said, if you're someone who needs to go to the what to do now, then head towards the second part of the podcast and you'll probably be able to find those effectively as we go through. Just before we get in these, this is not medical advice. I'm not suggesting that you should take any of the medications that we discuss, I'm not suggesting you should take any of the lifestyle things and go and do them. You need to work with your team and know yourself. I'm just giving you basic information around what is currently understood about insulin resistance with type 1 diabetes and things that have been shown in research to actually be beneficial. So first of all, we need to define what insulin resistance is. And in classic studies, they do something called a euglycemic clamp, where essentially what they do is they infuse a load of glucose and infuse a load of insulin to try and maintain the glucose level at a certain level. And they see how much insulin is required to put that glucose away, essentially. And the less insulin that's required, then the better the insulin sensitivity. The more insulin that's required, then obviously the higher amount of insulin resistance there is. And that's very, very accurate. But unfortunately, you can't use that for people with type 1 diabetes because they don't produce their own insulin. So obviously you can't use that there. So that's important to note. What I will say is what you can get a good approximation is how many units of insulin per kilogram that you weigh. So a healthy adult without diabetes would normally produce about 35 units of insulin a day, which is about 0.4 units per kilo. And obviously there are people with type 2 diabetes who their own pancreas are producing like 120, 200, 300, 400 units a day. And obviously they have insulin resistance. But as a baseline, roughly about 0.4 units per kilo would be the level of insulin required for a person without diabetes. And we know for people with type 1 diabetes, that can range massively from as low as 0.2 units per kilo to as high as 2.5 units per kilo in some examples. But to give you a bit of a clue and a bit of a guide, you take how many units of insulin you're on, you divide it by your weight, and you will get a number that will be somewhere between 0.2 and 2.5. And to give you an idea, people who are very sensitive to insulin and have no insulin resistance would be on about 0.4 units of insulin per kilo or lower than a day. Someone who'd be defined as insulin sensitive would be somewhere between 0.4 and 0.5. And then when you start getting above 0.5, there'll be a slight level of insulin resistance to 0.5 to 0.7. More insulin resistance, 0.7 to 1 unit per kilo. And then when you get above 1 unit per kilo, that's where insulin resistance is a little bit higher. And to give you a clue, only about 15% of people are very insulin sensitive, and around about 10 to 15% are very high insulin resistance. Most people sit in just like a little bit of insulin resistance between 0.5 and 1 unit per kilo. For children, that's a little bit higher because they generally have higher insulin requirements, sort of the lower range 0.4, the higher range 1.2. So that's kind of in the show notes, you can have a look. So I'm sure there's quite a few people at this point who've just gone, oh my God, I've got a level of 0.9 units per kilo or 1.2 units per kilo. I'm going to, keel over tomorrow. That's absolutely not the case. It's just saying that what would be the most insulin sensitive and lowest risk would be down at 0.4. But if you're currently at 1.2, making a meaningful reduction down to 1.1 or 1.0, if you're at 0.7, getting down to 0.6 would be hugely beneficial to your future health, just like going from 60% to 70% time in range. So that's the way to think about it. It's not trying to get 90% time in range or get 0.4 units per kilo. It's about maybe making some simple adjustments if you feel like it's important to you to adjust lifestyle and potentially medications to get your insulin units per kilo to a place where you feel confident with that. And you can check that out again in the show notes. One thing to say here is not all people with type 1 diabetes are born equal. So I'll tell you that my typical usual insulin dose, and I'll get to this in a minute, was about 30 to 35 units per day. I weigh 100 kilos, so that's about 0.35, which puts me at less than 0.4. And it makes it seem like, wow, I could be really smug. This amazing diet that I've got on loads of activity means I've got a low insulin, resistance or very insulin sensitive. But the reality is, I've had my C-peptide tested, which is how much residual insulin is being produced by my pancreas. And that's actually about 100 picomoles per litre. Anywhere less than 200 is typically what the person with type 2 would be, or type 1 would be. But there are lots of people with type 1 diabetes who will be down at a C-peptide of less than 5 picomoles per mole. And the reason why that's important is the more insulin production you still have left in your pancreas, the easier type 1 diabetes is to manage. And we've seen that time and again, and I've put some links into the show notes so you can have a look at that. And that might be something worth asking your clinician when you go. And it's also an important note not to just compare yourself to anyone else. So if you're thinking, wow, he's got less than 0.4 and I'm at 1.2, it's not about comparing to other people. It's about where you're at the moment, and do you feel like with some lifestyle changes or some medication changes, you could reduce that insulin resistance. So now you understand that people with type 1 diabetes are bound to have a higher insulin dose because they're putting it into the periphery and they miss the opportunity of storing a lot of glucose in the liver. We understand that. Now we need to think about what these different types of insulin resistance can be, which can cause a much higher insulin requirement, and especially in the light of type 1 diabetes. So what we know is that if people have beta cell dysfunction in the pancreas, that makes them more insulin resistant. So people without diabetes, if their beta cells are not very good at producing insulin, they end up being more insulin resistant. And the reason is that when the insulin is released from the beta cell in the pancreas, what it also does is goes to the alpha cell that produces glucagon, and it stops the alpha cell producing glucagon. So as you can imagine, after eating, the glucose level rises, the insulin level rises, and a person without diabetes, the insulin stops the glucagon production by the alpha cell, and therefore the levels stay low. But people with type 1 diabetes virtually don't have that to happen. So they eat, the insulin goes from the outside, not the actual beta cell itself. Therefore, the glucose goes up and the glucagon production increases. And as glucagon goes up, it goes to the liver and causes the liver to push more glucose out. So that's why after meal glucose rises are very challenging for people with type 1 diabetes and requires you to give even more insulin to overcome that. And this is why I'm saying people with C-peptide are at an advantage here, because they still have a little bit of insulin production left in the beta cells. Therefore, they get some of that negative feedback on the alpha cell and says, hey, stop producing glucagon because we've just eaten. That doesn't happen with someone with a C-peptide level that's basically undetectable. So this is one particular reason why people with type 1 diabetes have trouble with insulin resistance, is because they can't turn down the glucagon production after eating, which becomes a real problem. So that's problem number 1, the beta cell. Problem number 2 is the muscle insulin resistance. Okay, so resistant to insulin in the muscle, and how this happens is when someone has a high level of fat inside the muscle cells, and someone who's not doing lots of activity, they get a buildup of fat within their muscle cells. What they actually find is the fat cells is like a tadpole with 3 little legs on it, if you can imagine, or 3 tails. And what happens is when some of those tadpoles, some of those fats inside the muscle cells turn from a 3-legged tadpole to a 2-legged tadpole with a hydroxyl group called a diacylglycerol, it's basically just a different type of fat that actually blocks the insulin signaling inside the muscle cells. So if you're someone who's not very active, who's got a buildup of fat in your muscle cells, that causes the fat to stop the insulin working as well. Therefore, you need more insulin to overcome that. So basically, the less active that you are, the more muscle insulin resistance you'll have, the more insulin you'll need to put in from the outside. Therefore, you'll have even higher circulating levels of peripheral insulin, which again is going to be linked to those cardiovascular problems and potentially all cause mortality. So again, basically, inactive muscles, increased fat inside, increased insulin resistance, more insulin is going to be needed to be put in from the outside. And then we also have liver insulin resistance. And again, why this is going to happen is, as you can imagine, the liver is supposed to release glucose when you're fasting and stop releasing it when you're eating, obviously. But that doesn't necessarily happen people with type 1 diabetes because of that increased glucagon that we just discussed. So actually the liver continues to release glucose after meals, and that further causes the liver's ability to again shut off this glucose production, and actually then turns on both stored glucose being released and the production of extra glucose from amino acids from proteins. So again, that increased glucagon basically causes the liver to push more glucose out. And again, if you end up with getting, say, overweight and some higher fat in the liver, that has the same problem of the liver insulin resistance, similar to the muscle. And this is a big one, the next one, which is factor cell dysfunction. And this is what I see a lot in clinic, and I think is the most unfair thing for people with type 1 diabetes. When you've got a high circulating peripheral level of insulin, what it does is it goes along to the fat cell, and the fat cell has a front door which allows fat to go in, which you can think of as lipoprotein lipase. That's basically the front door. So the insulin comes along, grabs hold of the front door, opens it, allows fat to go in. And at the same time, a high level of insulin shuts the outdoor of the fat cell, which is hormone sensitive lipase. It actually shuts the back door, no out. So the indoor's wide open, the outdoor is shut, so all the fat accumulates in the fat cells and doesn't get the chance to come out. So it is extremely frustrating when a person with type 1 diabetes tries to lose weight because they've stopped eating as much, but because their circulating peripheral level of insulin is really high from before, maybe at like 1.2 units per kilo, even if they're eating very little food, they have an inability to actually release fat from the fat stores. So they're almost starving because they're not eating food from eating, and then also the body's not helping them because the fat that should be being released to produce energy is locked away in the fat cell because the peripheral circulating level of insulin is really high. So that is super frustrating for people with type 1 diabetes, and that is the one that I see the most with people who are trying to lose weight. They work really hard with the diet. Their insulin dose reduces a bit, but not that much because of previous insulin resistance, and they give up because it's just too hard. And there is some ways to combat that, but that is something very common and makes it difficult. I always explain it to people that if you had an identical twin and you were both overweight, and then one had type 1 diabetes and one didn't, and they both ate the same with a reduced calorie intake of, a reduction of making sure they were only eating 1,000 calories a day, the person without type 1 diabetes would lose significantly more weight than the person with, especially if that person previously had high circulating insulin levels. So it's particularly unfortunate. The kidney insulin resistance is again another thing that is extremely frustrating. Is within the kidneys, you've got something called the SGLT2 transporter, which is responsible for retrieving glucose out of the kidneys and making sure it stays within the body, because ideally you're going to need that. So you want it to absorb it. What is unfortunate is when insulin resistance is present, instead of down-regulating that reabsorption, it actually up-regulates it, so that works even more effective. So you end up absorbing even more of the glucose back, making the high glucose levels worse. So again, insulin resistance causes those SGLT2 transporters in the kidneys to grab glucose that's going to be filtered out in the urine and puts it back in the system. So again, high levels of insulin makes you absorb more glucose back from your kidneys, which seems to be the wrong way around and is particularly frustrating. Then there is brain insulin resistance, and this is where a high insulin level, a high circulating peripheral insulin level, as we've discussed, is much higher in people with type 1 diabetes, actually goes along to the hypothalamus in the brain and essentially interrupts the signaling process, and the hunger hormones actually decrease and the storage hormones actually increase. So that is a real downside of higher circulating insulin levels. It basically means that you're feeling hungrier and you're at more propensity to actually gain fat mass, essentially. Number 7 is gut hormone dysfunction. I'm sure most people have heard of glucagon-like peptide 1 or GLP-1 or semaglutide or tirzepatide or Mounjaro. And essentially what these two hormones are, GLP-1 and GIP, is they're hormones that are produced from your gut, your intestine, and they do lots of things. They make you stimulate insulin release for when you need it, which turns down glucagon production. They signal to the brain that we're full, so we don't eat as much, and it actually slows down the stomach emptying so that the food stays in the stomach for longer. And again, it has a huge potential benefits. What would happen in normal metabolism is you would eat, these things would go up, the glucose levels would go in control, your hunger would be normal, and you would just then consume foods normally. But we know as insulin resistance goes up, also your body becomes resistant to the impacts of GLP-1 and GIP. So as insulin resistance go up, your peripheral circulating level of insulin goes up, the GLP-1 and the GIP-1 decrease, and you can imagine that then becomes very challenging in terms of managing glucose levels and weight. And then finally, the last one is hyperglucagonemia, which, as I've described, because there is the beta cells are not working in type 1 diabetes, that means that glucagon is going to be increased. That means that then that is going to be increasing its output, especially to the liver, causing the liver to push glucose out, especially overnight, causing essentially, higher glucose levels in the morning. So insulin resistance and hyperglucagonemia sort of basically go kind of hand in hand as well, which is, again, extremely kind of frustrating. So now we've discussed the 8 different routes of insulin resistance. Let's actually get to the important stuff, which is what can we do about it? So we'll build from this, from the lifestyle into the pharmacology section. Obviously, the baseline level for all of this is going to be lifestyle. And we said the first and most important thing that you can do is have a high level of activity. And essentially, it doesn't matter, whatever level of activity that you do is going to be beneficial at reducing your circulating need for insulin in several ways. So the first way is we know when we're active, the blood flow around the body is much more effective. So as we've discussed before, we know that in people with type 1 diabetes, the main way that insulin actually gets deactivated is via the kidneys, which often means then we have to push the insulin level even higher. Whereas if you're more active, less insulin goes to the kidneys, more to the peripheral blood supply. You actually get more bang for your buck with the insulin dose that you've given. The second thing is activity actually opens a side door to the muscle cells, which means that you don't need insulin for some of that, which means that your insulin requirement goes down. So again, you'll reduce the circulating level of insulin. And then finally, as you're reducing the circulating level of insulin, you will then will also be increasing your fat burning within your muscle cells. So if you do have stored fat in your muscle cells, which is causing some insulin resistance, it will obviously reduce that down. So activity is the most potent way to actually reduce your insulin dose. Just as an example here, I've had multiple injuries over the last 7 years, and times where I've been out of action for 6 months because of either a broken ankle or shoulder rehabs. My insulin dose goes from 35 to 45, 50 units. And recently, I've really been struggling with my movement because of my foot and back issues, and my typical daily insulin requirement has gone from 30 to 35. It's now at 45 to 50, and that's over the space of about 3 months. And that's because I've gone from doing 90 minutes of activity a day down to about 15. So you can just see simply there, I'm getting close to increasing my total daily dose by 50 to 60% over 3 months of inactivity. If that carries on, the likelihood is I'm going to go from 0.4 units per kilo today, I'll be up in the 0.6, 0.7. So again, activity is the main thing that you can do, and it can be anything. So key things that we've discussed on here before, 10 to 15 minutes walking after meals will make the insulin work much more effectively. Doing aerobic activity, stuff that is kind of one paced, will burn some fat out of your muscle cells, sort of 3 to 4 times a week. It could just be fast walking, or it could be cycling, could be anything. Strength training would actually improve your muscle size, which then improves your insulin sensitivity. But key thing is, don't spend too long sitting. There's a lot of research to show that even 3 minutes of moving around every half an hour will reduce the insulin requirements and improve your time in range. Just think of it like activity snacking. And we did that podcast, I think it was podcast number 8. So check that out. So activity, get your 150 minutes of activity in a day. Really prioritize walking after meals. That is the baseline for improving your insulin sensitivity. The second one is weight loss. So if you're someone who's currently overweight, the more fat tissue that you carry, the more insulin resistant you're going to be. So even losing 5 to 10% of your body weight can really improve your insulin sensitivity. If you've got quite a lot of weight to lose, 15 to 20% will be particularly effective at reversing some insulin resistance, particularly in the liver and the muscle. And you will be also reducing the fat content in your muscles if you lose some weight. Just some key strategies for weight management if you're going to consider it. Really prioritize your protein intake, getting it to 1.5 to 2 grams of every kilo that you weigh, and try to incorporate some strength training so that you retain your muscle mass as you lose the weight, so you lose muscle fat rather than muscle. And that doesn't need to be anything crazy. Some calisthenics will do. Get a calorie deficit of about 500 to 1,000 calories per day, and obviously eat as healthy as you possibly can. And obviously sleep. Get your 7 to 9 hours sleep is massively important to improving your overall metabolic control. In terms of nutrition, what you can do, so nutrition things that will help with insulin resistance, there's obviously the key one is saturated fat is the one that causes the biggest amount of insulin resistance. So if you're having meals that are particularly high in sort of cheese, pizzas, takeaways, and they're really high in saturated fats, that's something that will really disrupt insulin signaling. So keeping your saturated fat down. Consider a moderate carbohydrate approach, sort of somewhere between 25 to 40% of your daily calorie needs can sometimes help reduce insulin dosing levels. A real key thing is trying to limit sugar. So the reason why that is, we know sugar is made up of glucose and fructose. And it is the fructose element of it that is particularly problematic, because the fructose part of the sugar goes into the liver. And when it goes into the liver, it causes a cascade which flips something called the fat switch, which is actually AMP deaminase. And there's a diagram on the show notes that will show you that. But essentially, keep it simple, that especially liquid drunk sugars, the fructose part of that will go into your liver and flick a switch and make it more likely that the calories you're consuming are turned to fat. So for me, that's why I use glucose only hypo treatments rather than sugar ones, because I would prefer the glucose treating the hypo, and I certainly don't want too many fructoses from that sugar going in to my liver. Just on a note there, fruit is absolutely fine because it goes in very slowly and in moderated quantities. It's the sugary drinks that are the main issue. Obviously, the higher the fiber in the diet and whole meal things will really help slow down glucose after meals, therefore generally need less insulin. And obviously pre-bolusing as well is important to make sure we keep on top of those glucose excursions after meals, so we're not having too higher insulin doses. So really just a healthy diet essentially is the key, and really limit sugar drinks is the key thing. So here's the big one. So they're the lifestyles. Be as active as you possibly can. If you've got weight to lose your weight, and follow a healthy diet. They're going to be nothing new to you. So what is important here is, if those things are working well for you, but you're still overweight or you're so insulin resistant that you're struggling to lose weight despite doing those things, which can be very, very common, I would still encourage you to do all of those things, but you may then want to consider discussing with your doctor options for reducing insulin resistance and weight management. So the first ones that would be the most obvious would be the GLP-1 receptor agonists. The probably most common one now that you'll know, semaglutide or Ozempic or tirzepatide and Mounjaro. Now, the older GLP-1s, such as liraglutide and dulaglutide, have actually been shown to be effective at improving HbA1c, reducing total insulin dose by about 10 to 15%, and weight loss by about 5 to 10%. So there is actually very strong evidence in type 1 diabetes that is effective. But realistically, those can be prescribed for people with type 1 diabetes, but often now the thinking is, well, if those ones are good, what about the newer ones like semaglutide and Mounjaro? Are they going to be better or not? So just as a little note, semaglutide is GLP-1 only, whereas tirzepatide or Mounjaro is a dual agonist that has GLP-1 and GIP. And just so that you kind of get a bit of a feeling for that, is the GLP-1 again will reduce glucagon secretion for a person with type 1 diabetes, will slow the gastric emptying, make them feel fuller for longer. What you get with the GIP is you also get some increase in adipose tissue blood flow and can increase your fat burning potential, essentially. So in theory, the dual agonists would potentially be better. So what does the evidence say? So for people with type 2 diabetes, you generally get about a 2% reduction in HbA1c, 15% reduction in weight for semaglutide. But for tirzepatide, you get a 2.5% reduction in HbA1c and a sort of 22% weight loss. Tirzepatide or Mounjaro is proving more effective in people with type 2 diabetes. What about the evidence for people with type 1? Why would it be extra beneficial? Well, as we discussed from an insulin resistance point of view, people with type 1 diabetes have a huge problem with high glucagon levels after eating. Well, we know that increased levels of GLP-1 and GIP will actually reduce the glucagon output after eating. So that is a particular benefit for people with type 1. We know that people with type 1 diabetes have more insulin resistance or circulating peripheral levels higher than people without type 1. Therefore, being able to go to the hypothalamus and restore some of that signaling is really important. And then also, because the food is absorbed much slower, you don't get as big post-meal glucose rises and you don't feel as hungry, you're going to get lots of benefits. So there's 3 potential big benefits that are sort of additional benefits for people with type 1. So what does the evidence say? Well, for these new ones, it's very limited. There has just been published one randomized control trial for semaglutide, which has shown over 6 months, you get about a 10% weight loss, a 3 millimole or 0.3% reduction in HbA1c, and a 10% improvement in time in range with no increased risk of side effects. So that has obviously been shown to be effective. And there's also been not a randomized control trial, but an observational trial of 26 adults with type 1 using tirzepatide. And compared to them before taking it, there's a reduction of 0.6% in HbA1c, or 6 millimoles per mole, a body weight reduction of 10%, a time in range improvement of 13%, and a total insulin dose reduction of close to 30%. And it was well tolerated. So you've probably listened to this and thought, right, brilliant, the evidence is there, they must be able to prescribe that now. Well, the reality is a randomized control trial of 26 adults and a observational trial of, less than 30 is not really the same level of evidence that we have for people with type 2 diabetes and general weight management, where there are thousands of people. So at the moment, they will not be funded by the NHS, by your insurers, but some doctors will prescribe off-label if you have one of those doctors that may do that. And also some people they are available to purchase online, where you would have to obviously lie if you were going to do that, because it's not indicated for people with type 1 diabetes. Some people are taking that route. I'm certainly not promoting that because there are serious risks with that. For example, you won't have your liver enzymes monitored. You won't have a structured way of reducing your daily insulin dose. So you could find higher risks of hypoglycemia. But some people are doing that, so that's up to them for consideration. If you are going to do that, I would encourage you to read the full article because, for example, you're going to need to lower your insulin doses by 30% very quickly. You have to be careful with side effects. You need to think about insulin dosing for meals because it's going to slow down gastric emptying. And if you're not on an AID system, that's going to have some challenges. And you should really pair it with strength training and protein intake to make sure you lose fat mass and not muscle mass. So again, whether you're doing this with a doctor off-label or you've decided to do that on your own, be very careful and obviously follow the best advice that your doctor's giving you, or do your research if you're deciding to go solo, which obviously I'm not promoting. Number 5 is an SLG2 inhibitor. As I said to you, the kidneys, the SLG2, reabsorbs the glucose from the kidneys back into the bloodstream, which it's supposed to do, evolutionary, but that is increased massively for people with high insulin doses. So if we could block that action of that SLG2, which is what some of the medications like empagliflozin, dapagliflozin and canagliflozin do, they've been shown to be very effective at reducing HbA1c and lowering weight. And there's something that are actually indicated for people with type 1 diabetes, because that actually reduces, if you take one of those, it means more glucose goes out in the urine, and therefore that's going to reduce your calorie intake, reduce your insulin need, and actually you can lose up to 40 to 120 grams of glucose per day. So maybe 40 to 120 grams of the carbs that you're eating would actually be blocked. And again, these are available to be prescribed for people with type 2 diabetes. So again, that might be something worth considering, although you have to be careful. There is a risk of diabetic ketoacidosis if the insulin doses go very, very low and the glucose metabolism really reduces down and causes high ketone levels. So that needs to be monitored. So again, that's just something to keep an eye on, but something to discuss with your doctor if you feel that would be beneficial. And there are lots of kidney and cardiovascular benefits of those two. And then the final one from a pharmacology point of view is something called pioglitazone. So typically the understanding of these things is they're not used very often because they can lead to a little bit of increase in weight. But this is often misunderstood, because if you had something that actually redistributed the fat that you had, it took it away from the liver and the muscles where you don't want the fat and put it into your fat stores, you would want something like that, because it would reduce your insulin resistance and it would make your insulin signaling better and reduce your total daily insulin dose. But because the early research showed that pioglitazone actually did this, but the weight didn't really change, or the weight may have increased slightly, it was seen as a potential negative that someone was gaining weight without the understanding that it had actually redistributed the fat from where you don't want it, the liver and the muscles, to actually your fat tissue where you do want to store it, where it doesn't cause the insulin resistance the same. So again, this is something worth discussing, especially if it was paired with a GLP-1 receptor agonist. You would get the benefit of the weight loss and also redistributing the fat away from the liver and the muscle cells and into the fat cells. But if you're taking an agent or you're being careful with your dietary intake and exercise, potentially again you would get the massive benefits. The final one on the pharmacology is metformin. Metformin is actually thought of an insulin sensitizer. So I used to describe this as, it works like WD-40 by making the insulin work better at the muscle cell. But actually, when I listened to the podcast by Ralph DeFronzo, actually, it doesn't get into muscle. The only place that metformin works is in the liver. And it works in the liver by disrupting fat oxidation, therefore prioritizing the liver using glucose. So it basically means that the liver uses glucose instead of fat for energy, and therefore can reduce the glucose levels. It doesn't actually improve your insulin sensitivity necessarily. It just reduces the glucose output via your liver. So it may be beneficial. It's actually shown that research it might reduce the insulin dose by about 5% in people with type 1 diabetes. And it does have a really good safety profile. But in terms of potency compared to the GLP-1 receptor agonists, the SLGT2s, and even pioglitazone, it's nowhere near the same effect in terms of the benefits of insulin resistance. So obviously that's a lot to digest. And the key thing here is to consider there are 8 different ways to be insulin resistance to happen, from the liver, the muscle, beta cell dysfunction, high glucagon, brain insulin resistance, gut hormone dysfunction, fat tissue dysfunction, and kidney dysfunction. Is that reality is, if you're someone who is currently, using high doses of insulin, just attacking one of those is not going to work. You're probably going to need 2 or 3 things to really help you. The things that's in your control: optimize your activity as much as possible, number 1. Number 2, if you've got weight to lose, look to lose weight. Number 3, making sure you have a low saturated fat and controlled calorie intake diet. Those 3 things are really going to help. But if you're certainly quite overweight at the moment, you might really want to think about some pharmacology to help you not only with the weight loss, but to get that total daily insulin dose down to protect your health in the future. And again, having that higher circulating level of insulin is one thing of the key things that prevents you from actually losing weight if you're keen to lose weight. So I hope that was helpful. Obviously, that's a lot of information to take in. It is something worth revisiting. There are detailed show notes with all the links to the study, so I'd encourage you to have a look at those and think about what things you can do if you feel this is important to you. And it's certainly something for me. Now my activity level is significantly reduced down and my insulin dose is on the increase. I'm starting to think about this and I'm like, right, time to put some of this into action. So with the injuries that I've got, I'm going to try and do as much activity as I possibly can, but it's really made me think of doubling down on my dietary intake, and also think about some potential pharmacology options in the future, should the insulin dose rise to a level that I'm basically not happy with. So I hope you found this helpful. Please share it with those who you feel might like it too. And then coming up, we've got a couple of things that we're going to go through. One is alcohol and type 1 diabetes management, which is a very tricky thing to manage, and we'll go through how to do that. And then I'm going to get Louise back on, who's the professional at the under fives, and we've done some work on how to manage type 1 diabetes with the under fives, and then we'll also do a separate one on, which is a really important topic for everyone with type 1 diabetes, which is how to manage your skincare, especially if you're wearing 2 or 3 devices, making sure that your skin's looked after so you can optimize your device management. So I hope you found this helpful, and again, please share if you do so, and feel free to leave comments at the bottom of the page. And again, just thank you for listening, and if you've made it to this far, well done. You've now basically, what's got taken me 6 years to understand, you've got it in, I don't know, maybe 30 or 40 minutes.